Hello, and thank you for watching my PowerPoint presentation. For this assignment, I selected an article published earlier this year in the Annals of Family Medicine. The title of the article is Behavioral Health Within Primary Care Postgraduate Dental Curricula, a Mixed Method Study. To introduce the article, the authors referenced a definition of behavioral health developed by the Substance Abuse and Mental Health Services Administration, or SAMHSA. According to their definition, behavioral health is the promotion of mental health, resilience, and well-being, the treatment of mental and substance use disorders, and the support of those who experience and/or are in recovery from these conditions, along with their families and communities. According to national data from 2019, at least 60 million Americans have some type of behavioral health condition. In recent years, two conditions have been particularly grown in severity: opioid use disorder, or OUD, and intimate partner violence, or IPV. Given the rise in prevalence of behavioral health conditions, the authors suggested health providers from a broader range of settings and professions need to begin screening and referring their patients for care. One such healthcare setting is dentistry. First, dentists and hygienists are likely to see their patients more regularly, which builds trust. And raising questions about behavioral health is dependent on trust between the provider and the patient. Second, behavioral health conditions, such as intimate partner violence and some eating disorders, have oral manifestations, making it easier for dental providers to raise the issues. However, little is currently known about the extent to which behavioral health topics are taught in postgraduate training programs in the United States. In the American dental care system, there are 12 dental specialties, such as orthodontics and oral surgery. In addition, there are two forms of residencies for general practice. The first is called an Advanced Education in General Dentistry Program, or AEGD. These programs are typically administered in dental schools. The other form is called a General Practice Residency, or GPR. These programs are frequently located in teaching hospitals or federally qualified health centers, settings where numerous referral options for behavioral health treatments exist. Of all these residencies, the AEGD and GPR options are the most common among dental school graduates. The aims of the study were to examine the integration of behavioral health training topics into AEGD and GPR programs, and to explore the facilitators of and barriers to integration of such training. The authors employed a mixed methods approach to answer the following research questions. First, to what extent are behavioral health topics integrated into U.S. training programs? Second, what program and individual level factors are associated with behavioral health curriculum integration? The main outcome the authors selected was defined as having at least 3 of 5 defined topics, which included anxiety disorder, depressive disorder, eating disorders, opioid use disorder, and intimate partner violence. The third question was, what influences, barriers, training strategies, resident outcome measures, and program outcome measures are considered in the integration? The target population for this study was program directors of all 270 AEGD and GPR training programs in the United States. Invitations were sent to all directors, but 5 were returned for incorrect addresses. The final sample included 265 programs, 2/3 of which were GPRs. The quantitative component of the project involved a 46-item survey containing a mix of multiple choice and Likert scale items. The authors developed their questionnaire by referring to an existing survey from the National Center for Integrated Behavioral Health and modifying it based on previous research and experiences in the field. Survey items asked about curricular content, mode of delivery, barriers to teaching, evaluation techniques, and assessing competence. Other items ask questions about program and individual director level factors. The survey was administered electronically using the Qualtrics software program and 2 email reminders spaced 2 weeks apart. The qualitative component of the study included a 14-item structured moderator's guide administered by 3 trained interviewers. The 90-minute interviews were administered by telephone, recorded, and then transcribed. 4 researchers reviewed the responses for common themes, and analysis proceeded until thematic saturation was reached. The sample for the structured interviews included a subset of program directors who responded to the quantitative survey. 44 expressed interest in being interviewed, and 13 of these programs were selected by way of a convenience sample. The authors used the explanatory sequential mix method design for this project. According to Cresswell and Plano-Clark, this design is useful when little information about key variables exists, and when the researchers wish to gain a deeper understanding of responses that occur during the quantitative survey stage. Given these factors, I believe the choice of this design was appropriate. First, there is little public information about behavioral health curricula in dental postgraduate training programs upon which the researchers could have relied. Second, the qualitative component gave the researchers an opportunity to explore the rationale for integrating behavioral health topics into training, including the perspectives of those making decisions about the curricular content. The authors acknowledged some limitations in their study. The first one was that resident opinions were missing from the assessments. Residents could have provided a richer understanding of what material was liked and what material might have been missing. The second limitation was that the program directors who participated in the structured interviews may not have been representative of all program directors. For example, interview directors were unlike the survey directors in terms of geography and age. The third limitation had to do with the lack of focus on content quality. Although the researchers were able to determine which of the 5 behavioral health topic areas were included, they had no way of assessing the quality of that content, a relevant factor to the larger research question. In addition to these self-identified limitations, I noted 3 additional concerns. First, in their analysis of the survey data, the researchers defined their outcome measure as including at least 3 of the 5 behavioral health topics of interest. This cutoff was arbitrary and, again, may have had little correlation with the quality of the content. Second, the researchers failed to discuss whether the survey was assessed for validity and reliability. Perhaps the survey was not a good measure of the topics of interest. Finally, the fact that 13 interviews did not necessarily represent the larger group of program directors means the qualitative results may not have been directly applicable to the questionnaire findings. These limitations aside, I thought the researchers conducted a reasonable study that filled some gaps in the existing literature. I have 2 discussion questions for my classmates. First, the researchers did not solicit information from trainees. If they were to continue their research, what are some behavioral health-related research questions that would be worth exploring with the AEGD and GPR residents? My second question is, what other fundamental mixed methods designs could have been used to answer this article's research question? And why was the method the author selected better or worse than the one you considered? Thank you, and I look forward to your comments.